Cellular senescence is no longer just a footnote in the biology of aging. It's increasingly seen as a central driver of age-related disease. From joint degeneration and osteoporosis to cardiovascular decline and neurodegeneration, the buildup of zombie cells seems to underlie a vast range of chronic conditions. As enthusiasm for senolytic therapy grows, so too does the complexity of a key question. Should we aim to systemically eliminate senescent cells throughout the body, or target specific tissues where they do the most harm? This debate, systemic versus localized senescence clearance, is more than theoretical. It touches on drug design, safety, dosing frequency, delivery mechanisms, and the ultimate promise of personalized medicine. And while both approaches offer compelling advantages, they come with distinct risks and challenges that demand careful analysis. Systemic senescence targeting has intuitive appeal. Aging, after all, is a global phenomenon, and senescent cells accumulate in most organs over time. Systemic senolytics, administered orally or intravenously, promise a whole-body sweep of dysfunctional cells, potentially restoring function across multiple systems at once. This could be especially useful in complex diseases like inflammaging, where senescent immune and endothelial cells produce widespread low-grade inflammation that impacts everything from cognition to cardiovascular health. Indeed, early mouse studies using systemic combinations like dasatinib and quercetin showed remarkable improvements in multiple organs simultaneously: better cardiac function, improved bone density, delayed frailty, even preserved cognitive ability. This breadth of impact from a single intervention is rare in medicine and suggests that systemic senolytics could serve as multi-morbidity therapies, fighting several diseases of aging at once. However, systemic clearance comes with higher risks. Senescent cells are not universally harmful. In small, acute bursts, they help suppress tumors, support wound healing, and remodel tissue after damage. A blanket removal of senescent cells could impair these beneficial functions, particularly in tissues that rely on rapid cell turnover, like the skin, liver, and gut. Moreover, organs differ in their permeability, microenvironment, and drug retention capacity, meaning that a systemic dose might clear senescent cells effectively in the kidneys, but not penetrate deeply enough into cartilage or intervertebral discs, which are poorly vascularized. This brings us to localized senescence targeting, which offers a more refined and potentially safer alternative. By delivering senolytic agents directly to affected tissues, we can concentrate therapeutic effects where they are most needed while minimizing exposure to healthy organs. In orthopedic contexts, for example, local injection of senolytics into joints or spinal discs could reduce inflammation, preserve structural integrity, and slow degenerative changes, without impacting senescent cells that may be performing useful roles elsewhere in the body. Such targeted approaches are already being explored. In animal models of osteoarthritis, intra-articular injections of senolytics like UBX0101 have reversed cartilage damage and improved joint function. Similarly, efforts to treat degenerative disc disease are testing direct intradiscal delivery of senolytic agents, though challenges remain due to the avascular nature of disc tissues. To overcome barriers to drug diffusion and retention, researchers are developing nanoparticles, hydrogels, and liposomal carriers that release senolytics gradually within specific tissue compartments, prolonging their therapeutic effect and avoiding systemic spillover. Organ-specific targeting also opens the door to precision senotherapy, where patient-specific biomarkers or imaging could guide drug delivery to high-burden areas. For instance, if imaging reveals localized senescence in the brain or arteries, targeted delivery might prevent neurodegeneration or atherosclerosis without inducing systemic toxicity. Gene editing tools like CRISPR/Cas9 or senescence-specific promoters could be used to activate senolytic action only in diseased cells, making future therapies both smarter and safer. Still, localized delivery is not without its limitations. Chronic diseases often involve multiple tissues. Osteoarthritis doesn't just affect cartilage. It impacts bone, synovium, ligaments, and systemic inflammation. Likewise, Alzheimer's disease involves not just the brain but peripheral immune cells and vascular dysfunction. Treating one site in isolation may not halt the larger degenerative process. Repeated local injections are also logistically difficult, invasive, and potentially risky, particularly in delicate or deep tissues like the spinal cord. This raises the possibility of hybrid strategies, using systemic senolytics intermittently to reduce global senescent burden, while also applying localized therapy in tissues with severe degeneration. Such dual-mode interventions could balance safety and efficacy, reducing whole-body inflammation while preserving organ-specific function. They may also allow for lower systemic doses, reducing toxicity while maintaining effectiveness. Dose and timing also matter. Unlike many drugs that require daily administration, senolytics may work best when given intermittently, clearing waves of senescent cells and allowing time for tissue recovery. This episodic strategy is already being tested in clinical trials and appears promising. The ability to schedule treatments, whether systemic or localized, based on biomarkers of senescence, could enhance both outcomes and tolerability. In the end, the choice between systemic and localized senescence clearance may not be an either-or question. It is more likely to reflect the patient's disease profile, age, organ vulnerability, and risk tolerance. A younger patient with early disc degeneration might benefit from a single targeted injection. An older adult with multi-organ decline may need broader, systemic support. Future protocols may include senolytic cycles paired with rejuvenative therapies, like stem cells or regenerative peptides, to maximize tissue renewal once the zombie cells are cleared. What's clear is that the era of one-size-fits-all anti-aging therapy is giving way to precision interventions rooted in cellular pathology. By understanding the spatial distribution, functional role, and molecular fingerprint of senescent cells across the body, we can tailor our interventions to do more than slow aging. We can reshape its trajectory, tissue by tissue, cell by cell.